All right, we are now live. Welcome, everybody. My name is Tim McMahon from St. Joseph Hospital, and tonight I am joined by some wonderful guests from our St. Joseph Hospital Cancer and Breast Care Centers, where we'll be talking about breast cancer, symptoms, treatments, common risks, uh, your commonly asked questions, where over the course of the next, 30 minutes or so, we'll be answering a lot of those questions that we get, but you'll also have the opportunity to ask questions throughout the broadcast as well, simply by typing in the chat box below. And when those questions come up, we'll be asking them of our guest speakers here, which I will introduce now. So, depending on how you're seeing it on your screen, I'll kind of go in order of my screen, but we have Dr. Bhatt with us right here in the top middle. And Dr. Bhatt is the medical director of our cancer center. So thank you, Dr. Bhatt, for joining us. Next to Dr. Bhatt, we have Dr. Manoli. Dr. Manoli is one of our breast surgeons in the breast care center. And thank you, Dr. Manoli. And below Dr. Manoli, we have Dr. Wendorf, who is our lead breast radiologist in the breast care center. And then to her left, we have Amy Devitt, who is from the American Cancer Society and is also a 18-year breast cancer survivor. So again, throughout the broadcast, if you have questions for any of our doctors or for Amy about, what it's like going through breast cancer and what the whole process is like and what it's like being a survivor, feel free to ask your questions in the chat box below. But we'll start with our questions first. And so, of course, I'm getting messages as we're talking. So I turn my volume off. But we'll jump right into it. So, one of the first questions that we always hear are, my doctor said I should get a mammogram starting at age 50, not 40. So, Dr. Wendorf, can you talk more about, what the advice really is?
Sure. So it used to be not so long ago when I started my career that there was no question about when to start your mammograms. Everyone just started their mammograms at 40, and there was a lot of compliance, and all doctors sent their patients around 40 for yearly screening mammograms. But things have changed, and mainly due to some guidelines set by a government agency called the United States Preventive Task Force in 2009, who issued some new guidelines that said women should start biennial, every other year, screening mammograms at age 50 and stop at age 74. And since this was so contrary to popular thinking, it created a lot of waves. So now I hear all the time that patients want to start their mammograms at 50 and only do every other year. And then that agency updated their guidelines in 2015. And it did say that patients should have the choice to start at age 40 if they value the potential benefit of screening more, and if they're given the information about the risks and benefits. But what basically everybody heard, because it was such big news, is start at 50 and every other year and stop at 74. But there's about 7 different major societies that have all issued guidelines now about when to start screening mammography, and they all differ mainly on when to start and when to stop. So we use the American College of Radiology guidelines because, which is to start at age 40, like the traditional way, and do every year because it saves the most lives. So some statistics that would be helpful to know, I think, is that 40% of the years of life lost to breast cancer are from women who are diagnosed in their 40s, and about 1 in 6 breast cancers occur in women from age 40 to 49. And there was a large Canadian study that over 2.7 million women that showed that the average death rate from breast cancer decreased by about 40%. And that was the same for women of all age groups, including the women in the 40 to 49 age group. So starting at age 40 results in the greatest mortality reduction, the most lives saved, and the most life years gained. And so that's why we abide by the ACR guidelines.
Okay, great. Thank you very much. All right. So this next question I'm going to ask to Dr. Bhatt. And that is, again, very common question that we hear often. is what are the signs and symptoms of breast cancer?
So when we talk about breast cancer, there's certain symptoms that should be red flagged or that should be brought to an attention to a provider. So the most common symptom is having a breast lump or a breast mass. Um, with that said, most lumps or masses are not cancer, but it's important to get it addressed. We know breast lumps that are, non-tender, maybe irregular in shape. We are more suspicious for cancer, but we also see patients who have very smooth feeling masses that can be painful. So having a lump or a mass of concern should be addressed. Other symptoms to address and have a provider look at is any changes to the nipple, any nipple discharge, um, for instance, bloody nipple discharge, any retraction of the nipple where the nipple is pulled in, any change to the skin of the breast. It can be change in color, red appearing, it can appear thickened. Sometimes people describe it as an orange peel appearance. Those are symptoms of concerns. And at times people note swelling under the arm, which is involving the lymph nodes and some of the lymph nodes in the collarbone. So any of those symptoms, it doesn't always mean it's breast cancer, but I think being aware of them and having a provider look at it is important.
Okay, great, thank you. So, along those kind of same lines, when we talk about the risks of breast cancer, who is considered to be at the highest risk?
So I'll go over the most common risk. It's being a woman and age. We know as women get older, their risk increases. There are certain risks that are considered higher risk, and that includes people with BRCA1, BRCA2 mutations. Those are genetic mutations. It's found in families. They have up to 70% risk of developing breast cancers. Other conditions include patients who have personal history of breast cancer, people who have maybe not breast cancer, but precancerous changes, atypia, where the cells are looking a little bit different, or ductal carcinoma in situ. Those are abnormal growth within the lining of the ducts. It hasn't become invasive. Having those changes, while they are precancerous, they're not breast cancer, they do increase risk for breast cancer. Additional risks include people who have gotten direct radiation to the chest between the age of 10 and 30. Sometimes it's environmental. A lot of times we encounter people who have gotten radiation for other types of cancers like lymphoma. And people with a strong family history. And we have various tools to assess a patient's risk, and that's based on personal and family history. And people with greater than 20% risk of breast cancer, those are considered high risk. Other mild to moderate risk factors include starting menses at an earlier age, so starting a period before the age of 12, later menopause, age of 55 or above, people with first pregnancy after the age of 30. Those are considered to be mild and moderate risk for developing breast cancer. It's important to be aware of risk factor, especially the higher risk, because that can sometimes change the screening recommendations. For some of those patients, we recommend mammogram even sooner than the age 40. And the other important point is sometimes we're able to do preventive treatment to further reduce risk of breast cancer in those higher risk groups.
Great, thank you. So again, kind of sticking along the same lines about family history, Dr. Manoli, if someone says, I don't have a family history of breast cancer, so I'm really not worried about getting it, do I still need a mammogram? What would you say?
Well, the majority of people who develop breast cancer actually don't have a family history. I think lately there's been this big push about genetics, which of course is important, and genetics does play into it if you have a family history. But The majority of our breast cancers are actually patients who have no family history and are found to have breast cancer. So absolutely, the same guidelines that Dr. Wendorf talked about, from age 40 on, you should have an annual mammogram. That's the recommendation for somebody who does not have a family history. And like Dr. Bhatt mentioned, if you do have a family history, that might put you in a higher risk category where you actually have recommendations to start mammography and potentially breast MRIs even at a younger age than 40. So absolutely, no family history, still need a mammogram for sure.
Can I add something to that?
Please.
I think that a lot of patients are under the impression, when I talk to them, I get the sense that they think that because we ask so much about the family history when they come in for their mammogram, we have an extensive history questionnaire. So I think they're given the impression that if they don't have a strong family history, they're somewhat protected. Because oftentimes I'll tell a patient, this finding that you're called back for turned out to be nothing. And they say, oh, I thought it was nothing because I don't have family history, So I think that we might give the wrong impression sometimes when we take our history. But as you said, I think it's 75% of women don't have any identifiable risk factors. So if we screen only women with risk factors, like some guidelines suggest, we'll miss the vast majority of patients who have breast cancer. And I might also add that breast density is now known to be an independent risk factor for developing breast cancer. And that's kind of dose dependent. So the more dense your breast tissue is on a mammogram, not by how your doctor feels your breast, but on a mammogram, the higher that risk can be. And it can be anywhere from just about 1.5 times the increased risk to 4 to 6 times increased risk for the densest breasts.
So that actually leads into another question, Dr. Wendorf, that, I was told I have dense tissue, so my mammogram is limited. Should I have an ultrasound instead?
And so when the patients come in for their mammogram, and the mammogram's read, we assess their breast density. It's in the mammogram report for every report. It's part of the FDA requirement. There's 4 breast density types, A, B, C, and D, and A and B are considered not dense, and C and D are different degrees of density. We attempt to tell all of our patients who are dense that they do have dense breast tissue, either at the time of their mammogram appointment, if their mammogram's being read the same day while they're here, or at least in the letter that they get sent to their home. And we do here recommend supplemental screening for women with dense breasts. It's an individual choice, but it's something that we offer. We know that mammograms are more limited if you have dense breast tissue because cancers are masked by the dense tissue, but it's also a risk factor. And when you add ultrasound for women who have dense breasts with a mammogram, we find more cancers. On average, screening mammograms find about 5 to 7 cancers per every 1,000 women screened. But that number is less if you have dense tissue. It's probably closer to like 2 to 4, depending on how dense your tissue is. When we add ultrasound with the mammogram for women who are dense, we find approximately 3 to 4 more cancers per 1,000 women screened. So your neighbor may have fatty breast tissue and their mammographic sensitivity is somewhere near 7 per 1,000. If you have dense tissue and you have a mammogram with an ultrasound, your sensitivity for cancer detection is somewhat similar to that.
And in what situations would a radiologist like yourself recommend an MRI?
So MRI is mainly done for 2 reasons. One would be for staging patients with newly diagnosed breast cancer. It's a much more sensitive tool for detection of early cancer compared with mammograms and ultrasounds because it looks at the breast in a whole different way. So mammograms and ultrasounds are kind of like basically fancy shadows. I tell patients the mammogram uses a fancy light source, which is X-ray, and the ultrasound uses a sound beam to bounce off of structures in the breast and create a shadow. And while that technology is very good, MRI is one step above because it's not looking at just the shadows or the structure of the breast tissue. It's actually looking at contrast enhancement, which is basically what that means is that's where the blood flow goes to in the breast. So tumors have abnormal vessels and they have more vessels, so they enhance more than the surrounding tissue. So we use MRI for women who are being staged for breast cancer so we can see if there's additional abnormalities in that breast where they have the cancer or maybe even in the other breast that we might have missed on the mammogram before they have surgery. And then the other major reason we do breast MRI is for screening for high-risk women. So as Dr. Bhatt mentioned, some women are at high risk because they have strong family history of breast cancer, which places their risk at greater than 20%. or they carry a BRCA gene, or they have a family member who carries a BRCA gene and they haven't been tested, or they have had chest radiation, for example, at a young age that increases their risk. So those women, we like to offer the MRI test in addition, not to replace, but in addition to the mammogram every year to get a more thorough look. We would offer MRI for all women as a screening tool, but it takes too much time to perform the MRI and too much time to read it, mainly. It can be expensive. Not all women can get in the position for the MRI or can have the contrast dye. And it can have a higher false positive rate. So that means like we find more things that are benign that aren't cancer, but they need to be worked up or sometimes followed or even biopsied. So we determined that risk of the false positive outweighs the small risk of the false positive test is worthwhile for the benefit of finding the early cancers for the women who are high risk.
Great, thank you. Now, when we think about causes and links in terms of like causation for breast cancer, one of the questions we hear is there a link between OCP and breast cancer? Dr. Bhatt, can you speak to that?
These are questions I get asked quite often, and we have a lot of conflicting information on that. So oral contraceptive and link with breast cancer. We know that certain patients, particularly as patients are getting older than age 40, who are on oral contraceptive medications, are at higher risk for breast cancer. With that said, there was a very nice Danish study a few years ago that noted the importance of balancing the use of oral contraceptive medication, its benefits versus the risks. Some people need to take these medications. They have painful or heavy menses, and we know there's some decreased risk for uterine cancer, ovarian and colorectal cancer. The study further noted patients who were on progestin-only oral contraceptive medications had a higher risk of developing breast cancer. But that said, the risk is still low. But the combination medications or the estrogen had a little bit of a reduced risk. So is there a link? There is a link. Is it a very high percentage? No, it's a low risk. I think the important thing to note is people who already are at high risk for breast cancer should discuss other means of other medications to replace oral contraceptive medications. The other point that came from the Danish study was people who had been on OCPs for greater than 5 years, their risk was increased. While this is not standard of care, a lot of people, for patients who have been on these medications for 5 years, will stop the medications if possible, take a holiday from these drugs, and then restart either with another kind of oral contraceptive medication or a different means of contraception. So I think it's important to discuss what are the risks and to balance the risks and the benefits of OCPs.
Thank you. And along those same lines, another question we hear often is there a link between hormone replacement and breast cancer? Dr. Bhatt.
So hormone replacement is used to treat menopausal symptoms. And again, we have different combinations. We have combination ones or estrogen alone, progesterone alone. The Women's Health Initiative study, the initial study noted that there was a higher risk of breast cancer of women taking hormone replacement. They had a follow-up study in 2020 where they noticed people who had hysterectomies, where their uterus had to be removed for a medical reason, who were placed on estrogen as their hormone replacement, their risk was actually reduced somewhat. So the biggest link in that 2020 follow-up was progestin-only hormone replacement was associated with higher risk for breast cancer. So again, it's important to have that discussion for both the hormone replacement and the oral contraceptive. If I have a patient who has breast cancer or at high risk, I try to find other means of or other medications that can give similar benefits, but not have hormonal manipulation associated with it.
Great, thank you. All right, moving on. Um, Here's a good one. I hate having mammograms because they hurt. Is there another test I can have? Dr. Manoli, what other options can people have?
Well, I mean, I still stand by the guidelines for people to have mammograms because it's an excellent test. I think Dr. Wendorf can speak to that, and she already has. But certainly we do supplement tests like mammograms with ultrasounds and MRIs. But I would not rely upon ultrasound and MRI exclusively without doing them in conjunction with mammography. Dr. Wendorf, did you want to add to that?
Yeah, I think sometimes patients try to come in and have only an ultrasound instead of the mammogram because there's no radiation involved, but we don't offer that service. The only test shown to reduce the mortality from breast cancer as a screening tool is mammography, and ultrasound doesn't have that data. And what I tell patients is the ultrasound and the mammogram are complementary. The mammogram is the best test to start with, and it shows very well areas of asymmetry because we see the entire breast in one picture, as well as calcifications, which are little minerals that can be a sign of breast cancer because they're denser, they're harder than our tissue. They show up very well on a mammogram. They don't show up typically on an ultrasound. And also areas of distortion with the newer 3D mammograms, we see that very well in the mammogram. But ultrasound's really just good. Its main strength is at finding masses and distinguishing them, like distinguishing cysts, which are fluid filled, from solid masses. So it cannot replace the mammogram. So we do not offer it as a standalone test, only in conjunction with the mammogram. And another test that some patients in this area have requested is thermography, which is a test that uses infrared to detect heat sources on the surface of the breast. There were trials studying thermography, mainly in like the 60s through the 80s. It mainly studied the thermogram in addition to mammography. And it did show if you did a thermogram and then added the mammogram, it did increase the cancer sensitivity. And it was even worse if you started with the mammogram and then added the thermogram, you didn't actually gain that much benefit. But there's no current evidence that supports the use of thermography alone as a standalone test. It would be nice if it did, because we radiologists would not be opposed to reading such a test. It'd be wonderful to be able to detect as many cancers as we do and have no radiation at all. But the dose of radiation from a mammogram is what deters most patients. And I think it's just misinformation, because the dose from a mammogram is similar to the amount of radiation you would receive if you just got in an airplane and flew from here to Colorado. And we don't even think about that radiation that we receive every day from our Earth or the atmosphere. And I think that the benefit of the mammogram greatly outweighs the potential harms. And another reason why I think patients are deterred from having the mammogram and want tests such as thermography or ultrasound is perhaps the pain, like you said. So I think everyone's pain threshold is different. Some patients, a few patients, complain that the mammogram hurts. Most just say it's a temporary discomfort from the compression. I think it's a small trade-off for catching a breast cancer at an early stage that's more treatable and may not even require high doses of radiation for treatment. And I think it's helpful for the patients to know too that they can reduce the discomfort from the mammogram if they schedule their appointment like the week after their period, because during your period and right before, your breast can be more tender. And perhaps they can take Advil or Motrin about an hour or two before the exam.
Great, thank you very much. So quick break here just to put up a phone number. So we've been talking a lot about mammograms and the importance of mammograms. So for folks who are watching that would like to make an appointment for a mammogram, here at St. Joseph Hospital, we have the number right here for you to call, make an appointment, get more information about the services offered through the Breast Care Center at St. Joe's. So we'll keep putting this number up throughout the broadcast, and we'll certainly put it up in the comment section after the broadcast, as this is recorded and will live on our YouTube and our Facebook page forever. So it'll be there for a while. So moving on, we're going to start trying to get into some more questions about, kind of like what happens after you've been diagnosed with breast cancer. And one of the questions, we often hear about different stages of cancer. And so one of the questions we hear is, how is breast cancer staged? Dr. Manoli.
So the staging for breast cancer goes from 0 to 4. 0 is what we would classify somebody who has in situ cancer, like ductal carcinoma in situ. Some people consider it a precancer, as Dr. Bhatt alluded to earlier, but I consider it a real cancer. But it stages as 0 because it does not have the ability to invade. And when we use the word invade, it sounds scary, but it means that the cancer cells can leave the breast and go to other parts of the body. That's what invade means. So stage 0 is an in situ cancer that's just in the milk ducts that cannot invade into other parts of the body. Stage 1 would be an invasive cancer that is confined to the breast and that's relatively small. Stage 2 would be a cancer that is either larger in the breast only or small, but has some invasion of the lymph nodes under the arm on the same side of the affected breast. And stage 3 would be a cancer that has a number of involved lymph nodes. Obviously, it started in the breast, but metastasized to a number of the axillary or underarm lymph nodes. And stage 4 breast cancer is one that has invaded beyond the breast, beyond the lymph nodes, and into other parts of the body.
Okay, and then to follow up with that, what's it? There's stages and there's grades. So what's the difference between stage and grade?
So we talked about stage, and a lot of people mix these two concepts up because they sound similar. Grade has a lot more to do with the cells. When the pathologists look at the biopsy under the microscope and they're looking at the cells, they're looking to see how closely the cells resemble a normal breast cell, because we know that cancer develops from a person's normal cells, and the cancer cells develop a sort of different trait where they can invade, like we just talked about, and they can also make a number of copies of themselves. The copies that cancer cells make are not quite normal looking, and that's how we, under the microscope, when we look at a biopsy, we can tell that it's a malignant cell rather than a normal cell. So the grade compares how closely the cancer cell resembles the normal cell. The cancer cells do maintain some features of their normal cells that they came from, and that would be considered like a low-grade cancer, where the cells of the cancer look pretty similar to their normal cousins. Then there's intermediate grade, where the cells have taken on a few more properties that make them look irregular under the microscope. And then there's high-grade cancers where the cells of the cancer really look different compared to their original breast normal cells. And so grade plays into how aggressive a cancer would be. Low grade, where the cancer cells maintain a lot of the features of a normal cell, tends to be a less aggressive cancer. Intermediate would be obviously in the middle, and high-grade cancers tend to be more aggressive because the cells have really taken on a very bizarre appearance. They've taken on a lot more aggressive features compared to a normal cell. So that's what grade means. It's really a pathological term, and by pathology we mean when we're looking at cells under the microscope. That's how we classify them as a certain grade. And staging has to do with how far the cancer has advanced within the body, and we just covered that. So a little different.
I find patients ask me all the time when I'm calling them with the results, they want to know what the stage is immediately.
Mm-hmm.
So we talk about the grade versus the stage, but I think they're most interested to find out how will they know and when will they know what stage they are. Like they want to know what stage they are right away. So maybe you can speak to like what kind of tests are done to determine, or like part of it is done during the surgery,
Right. So certainly staging, everybody, I agree, they want to know right away. And of course it's understandable because prognosis in terms of the cancer survival and outcomes is dependent on stage, but it's dependent on other things as well. Some of the staging is, a little bit of, we can do a little bit of what we call clinical staging based on how they present, how big the tumor is measuring on imaging studies, whether there's involved lymph nodes at the time that they're diagnosed. So we can have a bit of a clue as to their stage at that point. If they have involved lymph nodes or they have a 5-centimeter tumor on imaging, it would be a more advanced stage just based on those features. Sometimes staging comes later after surgery because part of what we do in surgery is take out the tumor and also evaluate the lymph nodes. And that's done in cases where we don't know if the lymph nodes are involved or not. So it's part of breast cancer surgery. Usually it's done by a sentinel lymph node biopsy, where we just have to sample a couple of lymph nodes rather than taking all of the lymph nodes out. And if the sentinel lymph nodes come back negative, then we know that the cancer was confined to the breast, and then the staging would be just determined by the size of the tumor. But if we do nodal evaluation in surgery and get back a result that shows some involved nodes, that increases the stage of the cancer. So a lot of times the cancer is diagnosed on imaging where the patient can't feel a lump, but they came for a screening mammography and we found something and they end up going to surgery. We're going to determine the staging during surgery when we evaluate those lymph nodes. And it doesn't come back right there on the day of surgery. Again, we got to wait for the pathologist to have a chance to look at the tissue, and then they come back and let us know the lymph node status. And at that point, we can give the patient a stage. Stage 4, which is the stage where the cancer has advanced beyond the breast and the lymph nodes. Occasionally we do, we diagnose patients at that stage. That's how they present. But that's a pretty rare circumstance. Most of the time, I would say the largest majority of our patients are actually stage 1 at presentation because they had their screening imaging studies. They had mammography that detected a small tumor. And so they're by and large mostly stage 1. And we obviously see all the stages. It depends also on the aggressiveness of the cells. But stage 1 are a majority of patients, and we find that out as a confirmatory after surgical pathology comes back.
Thank you. Now, I'm just curious, as we're talking about, patients coming in for their screening mammographies, we said patients should start coming in at age 40, but is that what we're actually seeing? I mean, if you look at, our average patient on any given day that comes in for mammography, is it typically patients in their 40s, or are we still seeing patients much older kind of coming in for their initial mammographies?
Well, it's all over the map.
Yeah.
Just the other day, I had a patient who was well into her upper 60s. But hooray, she started and now she's on track. In my training, I even had a patient who was in their 80s. But yeah, I see mostly patients in their 40s. Not everyone starts right at 40. I see mostly women between 40 and 50, but I have seen some patients starting at 50. And unfortunately, some of even our own providers are using the USPSTF guidelines, I think, or some providers in this area, and telling their patients to come at 50. But mostly it's women in their 40s that I see who start. And not all women should start in their 40s. As Dr. Bhatt alluded to, if you are very high risk based on your family history or genetics, we advocate you to start screening earlier. And so it's important actually for our doctors to be taking family histories in the office, because if a woman has a very strong family history, she may need to start screening earlier, but also genetic consultation. She may benefit from genetic consultation as well to determine if she really is truly high risk for breast cancer.
Thank you. Now, Amy, just to get you involved a little bit, what initially got you to go in for your mammogram? Was it because you felt something? Were you on that path of getting those yearly mammograms? What was your experience?
Thanks for that question, Tim. So I was 32 when I was diagnosed. We were in the middle of a home renovation, so I thought maybe I was just a little bit sore because I'd been doing a lot of unique lifting and bugging and tugging, but it was a definitive spot. I definitely felt a really strange round bump. And so I went immediately to my primary care, who kind of really at that time, now keep in mind, it was 18 years ago, was kind of like, maybe we could wait a little bit. And I really said, I really feel like I need to do more. And they agreed reluctantly, only because they said, you're not over 40, you don't have any family history, it's not there. But 3 short days later, I was diagnosed. So it was my instinct and it was my gut, and it was my great relationship with my primary care, because I had, she listened to me and she wanted to hear my concerns and encouraged me then to move forward with the test. So my message is to know your body. Make sure you do have a relationship with your primary care. And make sure you advocate for yourself and make sure you're aware if there are changes in your body, just like you've heard these physicians say this evening.
That's great. Thank you, Amy. Thank you for sharing that. So as we continue to talk about treatment, and especially once you've been diagnosed with breast cancer, obviously we all often hear about lumpectomies and mastectomies. And so, Dr. Manoli, can you talk a little more about how do you decide if someone's going to have a lumpectomy or if they need a complete mastectomy?
So just to clarify the terms, if anybody doesn't know, lumpectomy suggests a partial mastectomy or partial breast removal. We also refer to that as breast conservation. That's removing just the area of cancer within the breast. And mastectomy is a full breast removal. So sometimes it's dictated by personal preference. Some patients come in and they tell me, I want a mastectomy. Obviously, sometimes that's all the treatment they need and that's what they want, and we go forward with their desire. But the majority of patients come in asking for breast conservation or lumpectomy if it's feasible. And when I say it's feasible, it depends on the size of the tumor in relation to the size of their breast. If they have a very large tumor, or if they have multiple tumors that are kind of situated throughout different parts of their breast, a lumpectomy might not be the right choice for them because it wouldn't leave them much remaining breast, or if there's multiple tumors, it really isn't a good cancer operation to just take out a portion here and there. And a lot of the planning before surgery takes place between me and the radiologist because, it's very important that they look at the images with the surgeon so we can see exactly where all the diseased areas are and kind of make a game plan of what the best approach is to take those areas out. The simplest thing is a mastectomy. I don't have to think much about it. It doesn't matter where the tumor is situated. We just remove the whole area. But if the patient really wants breast conservation, I have to do a lot of work to make sure it's the right thing and to know exactly the area. But it really boils down to basically the nature of their cancer. Is it multifocal? Is it large compared to the size of their breast? And then we have a very long consultation, where I examine the breast and look at that in terms of size and shape. And I talk to the patient to figure out her preferences.
And with that being said, do patients also require chemotherapy before surgery, after surgery? What's common?
So probably the most common approach would be surgery first. That's the typical approach for most breast cancers that are found at an early stage. However, there are some subsets of breast cancer that we treat with chemotherapy first. And those are typically the more aggressive kinds of breast cancer, like a triple negative breast cancer or a HER2 positive breast cancer. The reason that chemotherapy is given first, and Dr. Bhatt, feel free to jump in anytime here, but there's plenty of studies showing a much more favorable outcome in survival and in cure rate if the chemotherapy is given first, because these cancers, they tend to metastasize early if they're aggressive cancers, and so the chemotherapy is able to tackle all the other parts of the body where the cancer cells might be floating off to. Whereas surgery really can only tackle the immediate area where the cancer is situated. So in the aggressive kinds, we would use chemotherapy first and then surgery subsequently. And then sometimes in patients who want to have breast conservation, they would like to have a lumpectomy. We will sometimes use chemotherapy upfront to try to essentially shrink the tumor in the breast so that we could get around it with a lumpectomy as opposed to having to proceed with a full mastectomy.
So one of our viewers just asked the question, why isn't immunotherapy given first? And is that chemotherapy she's talking about, or?
So immunotherapy is a little bit different from chemotherapy in the sense it kind of utilizes the immune system to fight off the cancer cells. And immunotherapy is not a standard of care treatment for patients with stage 1, stage 2, or stage 3 breast cancer. We are conducting research for patients with stage 4 breast cancers and particularly triple negative, we can use immunotherapy in conjunction. The only time that we might use immunotherapy in a non-metastatic setting is patients with advanced breast cancer stage 3, which is very aggressive. Usually they're triple negative. They have BRCA positive mutations. So those are the settings where immunotherapy may be used, but it's usually in conjunction with chemotherapy in those aggressive settings. It's different compared to other cancers like melanoma or cancers like that, where we might be able to use immunotherapy upfront. We have great data, it works, people have great response. We don't have that robust data in breast cancer.
Great, thank you, Dr. Bhatt. And so speaking of therapy, and Dr. Bhatt, maybe you can answer this one as well. What is preventative therapy?
So when we talk about treatment and prevention particularly, it is treatments which can be multimodality. It can be surgery, radiation, or medications, particularly oral medications that reduce the risk of breast cancer. So as previously stated, some patients who are at high risk or they have history of ductal carcinoma in situ or atypical ductal hyperplasia, those are precancerous breast changes. They're not breast cancer. We treat them with, for instance, the atypical ductal hyperplasia is a surgery alone. For the ductal carcinoma in situ, surgery plus radiation. And depending on their risks, we also discuss preventive therapy, endocrine therapy, which is hormone medications like tamoxifen or aromatase inhibitors. They're very different. I think sometimes we use them in a confusing way. It's not hormone replacement, which is completely opposite to endocrine therapy or hormone therapy used in this setting. In preventive therapy, it is to reduce the levels of estrogen and progesterone. We know the most common kind of breast cancer is estrogen and progesterone positive breast cancer. And with endocrine therapy like tamoxifen, aromatase inhibitors, they decrease the production of those hormones, basically cutting off the food supply to kind of feed the fire. So those would be preventive means of reducing risk of breast cancer.
Great. And then along the same lines, Dr. Bhatt, what is therapeutic therapy?
So that is for people who have a known diagnosis of breast cancer. So we're trying to treat breast cancer. And that's, as Dr. Manoli alluded, it depends a lot on the stage. It depends on whether they're estrogen and progesterone positive breast cancer, whether they are more aggressive, which would be HER2 positive breast cancer, or triple negative. They don't have estrogen, progesterone, or HER2 receptors. And depending on the stage and these characteristics, patients may simply need surgery, which can be lumpectomy plus radiation or a mastectomy. Sometimes patients who have axillary involvement lymph nodes in the under the arm area that are positive for cancer, they may need radiation in that setting as well, in addition to mastectomy. And then it's a discussion for most estrogen, progesterone positive breast cancer. They're detected early. We can talk about endocrine therapy to further reduce their risk. For patients who are HER2 positive breast cancer, we have targeted therapy. HER2 targeted therapy we can use with chemotherapy if it is at an advanced stage. And then for patients with triple negative breast cancer, which again tends to be more aggressive, and if they're at higher stage, we recommend chemotherapy. Most people do end up having chemotherapy post-surgery, but as Dr. Manoli mentioned, certain high-risk breast cancers, size of the breast cancer, and to achieve best surgical outcome, sometimes we do chemotherapy upfront, so neoadjuvant chemotherapy. And then finally, patients who have stage 4 breast cancers, Again, depending on the characteristics of cancer, we might rely solely on oral medications, endocrine therapy, plus or minus chemotherapy can also be used in that setting.
Dr.
Great.
Bhatt, I have a question for you myself.
Sure.
So, I'm typically the person who gives the patient the initial diagnosis from the core needle biopsy. And so, in addition to wanting to know their stage right away, most patients want to know if they need chemotherapy. And, my standard response is typically that not all cancers need chemotherapy. And the treatment varies depending on the time that you're diagnosed and what kind of cancer. But what would you say, like just a rough estimate, what percentage of patients do not need chemotherapy when you see them for a new diagnosis?
So most common breast cancer, most common that we see is estrogen progesterone positive. And with screening, we are able to have early detection. So most people do not necessarily need chemotherapy. We're able to do very conservative treatment, surgery, radiation, and then just endocrine therapy. And that's what I see in most patients in my clinic. And that shows the value of detection. It definitely affects treatment outcomes.
Great. Thank you, Dr. Bhatt. So, we are kind of coming down to the wire here in terms of our time this evening, but, really what I'm hearing, what I've certainly heard and seen over the last 2 years of working at St. Joe's is that we truly are a one-stop shop for, all your cancer and certainly breast cancer needs, from, diagnosis, the radiology, mammograms, treatment options, surgical options, like I said, chemotherapy options. So I think what's nice is that we have all this, in one place, in one building, with obviously fantastic providers. But it's nice that that you can access all these services close to home. And I think that's what we try to tell our patients and tell the community, is that when you're going through cancer treatment, or when you're first being diagnosed, you don't have to travel, down to Boston to get, top-notch care. You have it right in your own backyard. So, can you guys speak to that at all? That's usually what I'm telling people, and that's what I'm hearing, is that we have it all in one place, and that's, I think, one of the big benefits of St. Joe's, is that it's all here.
Well,
so
certainly from the screen, from the moment that the patient enters the breast center for screening, I would say it is a pretty comprehensive program, and that all of our patients do take a very detailed history. We get a detailed history from the patients, and we offer risk counseling for all of our patients who we deem high risk. And we're very comprehensive here in that we discuss all of the different screening options, like breast ultrasound for women who have dense breast tissue. Anybody who has dense breast tissue, like I said, we tell them that their breasts are dense and what that means, and that there are different options to add to their mammogram. Any patient who we deem high risk, we offer genetic counseling services right here, that's kind of unique for a hospital this size. A lot of places you have to travel to go see a genetic counselor. And oftentimes they're booked out for many, many months. And patients who are high risk, who we deem qualified for breast MRI, we do offer that service as well. And we do order it through the breast center. They don't have to get the order from their primary care doctor or get that authorization done through their PCP, which makes things very streamlined. And then having the surgeon right here in the breast center is a really unique thing. It's nice that the patient can come right back to the center where they had their imaging and their biopsy, and it's not a daunting task to try to find another office in another part of town. And then the fact that Dr. Manoli and the surgeons are here, they can look at the images with me, which I think is best care for the patient. As you said, Dr. Manoli, you review the images to determine if a patient is a candidate for a lumpectomy versus a mastectomy. So it's really nice that we're right here, because if you're in a different office, you wouldn't be able to have that consultation in person with the radiologist. And then Dr. Bhatt is also here in the hospital, just on the other side of the atrium. And so I do think it is kind of everything in-house. It's really nice for the patients. It's less scary, I think, than having to drive over to different appointments for everything.
Yeah.
Yeah.
Absolutely.
And Really nice collaboration, I think, between all the different steps in the process and all the different providers. You know, I don't have a problem picking up the phone or walking over to talk to Dr. Wendorf or Dr. Bhatt and just kind of reviewing everything as a whole and trying to figure the patient out and what's best for them and trying to expedite anything we can for them. We really do try to work for the patient and make sure that they're getting the things they need in a timely fashion. And it's nice to have that team approach right in the same place. And it's convenient for us too, because if something's not quite working the way we want it to, we can intervene at any step in the process and get it back on track. And the patients have a go-to place. They know who to contact and how to get things done and get their care back on track when they're not. So we work well together. It's a great place. I think we're pretty welcoming to the patients, and we're pretty good at communicating with them when they're not sure what's happening. It's a scary time in somebody's life when they get diagnosed, and we try our best to make it a less scary experience.
Great. Well, thank you. So just to wrap it up, let's just talk about a couple of resources that we have available to folks who are interested in learning more, that want to know more information about breast cancer or about treatment options. So Amy, can you speak to the American Cancer Society and what resources they have?
Yeah, I have the awesome responsibility of being the American Cancer Society's liaison to St. Joseph's Hospital. We have an amazing partnership, and we're there in your community to support you 24/7. So for more cancer information that's available at your fingertips, you can always check out www.cancer.org. And our NCIC call 1-800 number is 1-800-227-2345. We've always had live chat, and just over the past couple of years, we've actually been able to add video chat so that I, being a cancer patient at one time, woke up at 2 a.m. and I couldn't wake my doctor up. I'm not sure that would have been a good idea, but the 1-800 number was there for me to talk me through my concerns. And, you know, I contacted my doctor the next day, but it was sure reassuring to have them there in the middle of the night for me.
Great. Thank you, Amy. And Dr. Wendorf, you have another resource we'd like to share.
Yeah, so due to the confusion surrounding screening guidelines, especially when to start mammograms and how often, the Society of Breast Imaging has a wonderful website to help patients, and it's the sbi-online.org. And if you go to that website, there's a tab that says End the Confusion. And so if you click on that tab, there's a lot of interesting facts, a lot of information about why to start screening at 40, why to do every year instead of every other year. And it's a wealth of information. So I highly recommend that website.
Great. Well, thank you again. And just, I'd be remiss if I didn't mention it again. If you're watching this and it's time to make your appointment for a mammogram, please give us a call. The number is right there at the bottom. But you can also go to our website for more information. And if you lose this phone number, go to our website, and we have our phone number on there as well. So again, thank you all for joining us tonight. Thank you to our wonderful doctors, to Amy for all your incredible information, great stats, great information. We really appreciate it. And thank you everyone for joining us tonight. So if you have any more questions, feel free to put them in the chat box, and we can respond to those moving forward online. But thank you again, everyone. Have a wonderful rest of your evening.
Thank you.